Welcome to Voices of Care, the podcast series from Newcross Healthcare, which looks to address the key issues facing the health and social care sector workforce by speaking to the leaders and luminaries who are helping to enable the healthcare workforce of the future. I'm Sir Helen Hartley, and this is the second of two episodes we recorded at the LaingBuisson Private Acute Healthcare Conference in London. I was thrilled to have the chance to speak with some of the leading lights in the private acute healthcare sector and to get their insights on these crucial issues. I'm joined by Justin Ash, the Chief Executive of Spire Healthcare. Justin, lovely to see you. I want to start, if I may, with a couple of congratulations. It's 5 years, I think, since you've taken over at the helm. I don't think you could have quite predicted what they would bring, but the second congratulations is on your results that were published recently, showing growth across all your marketplaces. So an exciting time to be in this segment of the healthcare market.
Yes, thank you. And I'll start with a thank you to all our colleagues who delivered those results. Without them, I'd have nothing to say to you, so thank you to our colleagues.
Absolutely, and moving on to the colleagues, your results highlight the importance when you look forward of investing in your people to obviously meet the challenge of the continuing challenge of workforce shortages, which are across the sector. I know that Spire has focused a lot in terms of nurse apprenticeships and international recruitment. Can you tell us a little bit about that? Because there are clearly shortages.
Sure. Well, first of all, you'll have seen there is unprecedented demand for healthcare, from primary care to diagnostics, outpatient and inpatient care. So that's a real opportunity for the independent sector. But you can't meet that demand without a strong colleague workforce. And clearly there are shortages in the UK. We know that we're short 100,000 nurses in the UK. So at Spire we've been, as you know, planning for this and working towards this, partly through internal development. We've got the largest nurse apprenticeship programme. 5% of our colleagues are in apprenticeships, over 1,000 are having learning and development. And we've also got a very active, ethical international recruitment campaign and process. And these, frankly, without these programmes, we would have theatres that weren't working. And I think generally as a UK healthcare sector, we need first of all to celebrate the contribution of our colleagues, both recruited and trained in the UK and from overseas, and also to prioritise more the importance of really developing the cohort of our workforce for the future. And I don't think it's high enough on the agenda.
No, absolutely, and just to touch upon that briefly, the learning and development, you're an award-winning best workplace for learning and development from the Nurses Times, and that's right across the board at entry level, at clinician level. Tell us a little bit about that, because that's a fabulous recognition of the work you've done.
So thank you. So the team have worked really hard at this, and we really try to be a learning and development culture. We also have doctors in training. We have apprenticeships which are upskilling nurses, theatre nurses. We've got actually just a nascent but growing orthopaedic specialist practitioner programme, as well as nurses who've, in the main, by the way, come from the leisure industries. Post-COVID, there weren't so many jobs, and they're now training to be nurses, and they're already working as healthcare assistants and just fabulous.
That's expanding the actual workforce itself. A couple of final questions. We are at an inflection point. We've got huge elective waiting lists in the NHS. Would you agree it's now at a time where the independent sector is regarded as a complementary colleague, collaborative colleague, rather than a competitor?
I think the noises are very positive. If you look at the actual NHS commissioning, it hasn't really grown. That's a question for the NHS. Clearly every patient who goes private takes themselves off a NHS waiting list, and that's important. So I think we are collaborative partners. I guess most people would like to see that turn into a more consistent programme, but we'll see. Conversations are extremely positive, and there is some movement.
Wonderful. One final point, it's on a personal note. My son has begun university in Cardiff, and I just wanted to touch upon, you've had a major investment programme at your facility there.
Yes, we've invested very heavily in Cardiff, including new radiology facilities. That site's doing really well, and we're really pleased with its progress. And actually our positions in both Wales and Scotland are very strong. We work very collaboratively with local government, and again we've got some fantastic colleagues. So yes, thank you for raising it, and well done to the teams in Cardiff, in Yale and in Edinburgh.
Well, on that note, thank you so much for your time, and I know that everyone is waiting with bated breath for your contribution now, so thank you for taking time, and I look forward to catching up with you again.
It's great to see you again. Thank you.
My pleasure. I'm joined by Matt Hickey, CEO of Health Value Alliance. Matt, thank you very much for taking the time out to join us today.
You're welcome.
It's an exciting time here at the conference. Private acute healthcare, I think, is clearly bouncing back from a couple of years of challenges, the self-pay market, PMI. So are you seeing that in terms of the excitement and the opportunity and potential in the sector?
Yeah, I think the interesting thing of this particular conference versus other years is we're seeing a little bit of, probably a little bit more energy.
Yep.
A little bit more urgency probably is the word. So the conversations are a little bit more pointed, and we're getting to a point where we're saying, okay, we've talked about this for a long time. We know these issues have been coming. COVID clearly gave us a time to reassess, and but I think we're a year beyond that now, and everybody's turning around and saying, okay, what are we actually doing?
Yep.
So there's definitely an energy that I haven't seen in the previous conferences about getting something done.
Yeah, and delivering that for patients is obviously vital. We've got the elective backlog in the NHS. A predicate for doing that in the private sector is, of course, having enough staff. I know we're going to be talking about the work of the Health Value Alliance in a minute, but your own international perspective, it's a global issue, the workforce shortages. That's still something that's been come out in the themes for the conference today.
Definitely. It's clear that NHS, the issues they have, we have similar. It's been mentioned in some of the conference discussions already about what acute issues we have, discussions around the amount of international workforce that are or are not here at the moment, and the acute shortages. There's statistics like saying by 2030 we're 23% understaffed in the NHS. Well, that's just not the NHS, because we all come from the same staff pool.
Yep.
And therein lies the problem. So, and I speak internationally. I discuss with agencies all over the world, and we've all got the same problem.
Yeah, so that's the backlog. I want to segue away from that, from long experience in the sector, and the work of the Health Value Alliance. Obviously, it's looking at cancer. It's a huge issue, I think. Statistics I've seen, 10 million people dying of cancer in 2020. I think the projections are by 2040 we could have over 27 million new cases of cancer per year.
Correct.
So just looking at tell us a little bit more about the Health Value Alliance and your work. I know you're focused on sort of value-based outcomes, etc.
Yeah, so I think the title we chose for the business is pointed and purposeful. So health means different things to different people.
Yep.
Value means different things to different people, and an alliance means that we need to come together and work that stuff out. So you're quite right, we're looking at the principles or the foundations of what value means, but what it means to the different stakeholders in the ecosystem. So if we're talking to a clinician or a hospital or an insurer, and of course the patient, they will look at outcomes, cost, risk, value completely differently and measure them differently and fundamentally talk a different language. So somebody needs to be able to sit in the middle of that and translate to ensure that we understand what we mean by an outcome, for whom, and how do we measure it, and how does that become timely and meaningful for the different stakeholders to be acted upon.
And you're looking for a standard that can truly bring into reality this values and outcome-based oncology. It's a huge vision. What are some of the challenges that you're seeing, and what are the pathways you're adopting to get to that place?
I think the first challenge is this taxonomy, is getting to understand what we mean when we use these terms. So we're tackling that with European alliances and FHIA, etc. So that work's happening, we're aligned with that. The other was looking at the metrics. So what is real world? One of the big problems, we've got 700 cancer registries out there, and they don't talk to each other.
Wow.
Across the world. So one of the key things is that we all collect similar data. We just don't interact or interoperate with one another.
That's astonishing, really.
Yeah. And the electronic medical records, oncology record and verify systems, they're fundamentally similar beasts, technologically and data-wise. So if we can get a standard set of metrics around those key terminologies, around outcomes, PROMs, toxicity, etc., and understand how do we measure the root cause of value erosion, that means we can understand the clinical outcomes, we can understand the root cause of value, improvement or erosion, and then translate that crucially into cost. Because the whole infrastructure that we're working on is fundamentally based on money. If we don't have enough money and the cancer costs are increasing year on year to an unsustainable level, I think one of the speakers last year from Vitality mentioned that they got a 9% year-on-year inflation. That's not sustainable. So the system, in order for hospitals to coalesce around with insurers, around medtech, etc., around that patient, have to be equally sustainable, and that's the process that we're going through.
So by allowing, hopefully, commonality in terms of the data and the metrics, you're driving not only better understanding, but potentially efficiencies.
100%. And later in my conversation, in my talk today, I'll give a definition of efficiency, so I'm glad you used that term. But you're right, the commonality is important. So we need to be able to understand those key metrics. Not all of the measures will be right for each particular stakeholder, but we're pulling them from a standard metric base. They're real world, we collect them routinely each day in our electronic medical records, etc. And they're actionable, and they mean things to the people who are going to use them, so clinicians or hospitals or insurers who might direct care or understand their risk. And fundamentally, the outcome translation to cost. So that's the principles that we're bringing.
And that will play very powerfully in terms of patient outcomes, but also, as you say, we're living in a world where resources are finite, demand is inexorably infinite in that sense. But just to hone in on how far are we away from that in terms of the technology and the infrastructure, because it's a huge ask, but it potentially could transform the way we treat this disease.
I don't think we're far away. I think we're here.
Wow. Okay.
The difference is that we haven't brought the stakeholders to the table. Okay. So this disconnect between hospitals and insurers and patients and clinicians and all the arguments that or pointedness that's been going on in the conversation today, we actually need to bring those stakeholders to the table. So what we're doing differently is, firstly, we're not looking at the national standards or the UK minimum standards that we measure ourselves typically in the UK. We're going to look at international standards. If we're going to showcase ourselves in the UK as an exemplar in the world, what does that mean?
Yeah.
And that's bringing together pharmaceutical companies with insurers, with hospitals and clinicians, and sitting around the table and nutting that out, and really criticising the current models, pulling from an actionable model that we can go forward on and fundamentally agree on.
So there's a lot of advocacy you've got to do. Is the appetite there from all the stakeholders? Obviously, to varying degrees, you can't talk for everybody, but it sounds like someone listening into this seems like almost a no-brainer that it must be done. Is the appetite now, the time good for this?
The timing's perfect, actually, because the cancer funds, as I mentioned, are in trouble.
Yep.
We know that will translate to issues with regard to hospitals and sustainability. So the financial affordability and sustainability of the model is on everybody's tongue. So I think the timing and the data revolution is here. We've got the stakeholders around the table. Your question was, have we had the engagement? We've had almost too much engagement. So the difficulty is actually reining this into a manageable proof of concept before we really run off.
Okay, well look, it sounds like to me it's the timing, and in terms of all the stakeholders for the sector, including regulators and government, will need to be looking at the work that you're doing. So thank you so much for shedding some light on it, and I look forward to hearing you later in the conference.
Welcome. Thank you very much.
Thank you, Matt. Pleasure. I'm joined by Dr. Helen Hartley, Medical Director within Healthcare Management at Bupa Insurance. Helen, so grateful for you to give us your time here today.
Hello.
I wanted to ask, if I may, we're here at the Private Acute Healthcare Conference. Numbers are improving in terms of self-pay, PMI market. So from quite a buoyant time and an exciting time to be in this segment of the healthcare market.
Yes, I think with current trends and long NHS waiting lists, we've seen that the data is showing record numbers of people looking to the private sector to get their diagnosis and treatment. And at Bupa, we've passed 3 million members now, and we've heard this morning that self-pay is also growing very steeply.
Oh, that's very encouraging for everybody here at the conference. I wanted to touch upon a key area for the independent sector and generally, and this comes out, of course, the backdrop of the Patterson inquiry. A number of key themes for me, but I wanted to tie it back to the ambition that Bupa has to be the world's most customer-centric healthcare company, and to touch upon the importance of transparency and communication to patients, which is one of the key themes from Patterson. Just wanted to get your expert view of just how important that is and how we facilitate that.
Yes, I think it's fair to say the Patterson inquiry did throw up some areas where the private sector could do better, and I think having more information about the outcomes that are being achieved in the private sector to enable benchmarking, to enable more informed choice by patients and by funders, and also being able to see those outcomes and for providers and consultants to use them as the basis for quality improvement. So it seems to have two important purposes. And then separately, looking to Patterson, there is the performance management aspect. If a hospital can see the outcomes of all its consultants and the outcomes of the pathways that they're delivering treatment through, they're in a really good position to address any issues and try and improve the safety and quality of those pathways.
So it's a question of patient choice, but also in terms of clinician oversight and encouragement and driving of standards.
Exactly. It's all interlinked, and the root cause, the common pathway to achieving all of these great improvements in transparency, in quality of outcomes, in the ability to govern properly, is to have transparency of that data. And therefore, Finn's work driving a plan to be able to deliver the CMA order by 2026 is really important, because we need to make it business as usual to be collecting outcome measures when delivering private healthcare, so we can show people how good the quality is and hopefully keep a healthy marketplace with more customers coming forward to buy private insurance and to use private healthcare.
And to give confidence to the patients who've for a decade had the choice to go to private providers and be well informed. So that sounds like a fantastic achievement. The other thing that from Patterson for me that came out was the importance of regulatory collaboration in terms of standards. I know it's something that you're very passionate about. And can you just delineate how important that is in terms of ensuring that the standards are met?
I think that is a very important point. We have a number of regulators that impact on private healthcare. We've got the GMC especially, and the CQC, the Care Quality Commission, and they have oversight over the quality of practice in the private sector, just as in the NHS. And it's important that there is dialogue and collaboration among all the different stakeholders, because this is a complex area. There are many factors. There are issues of culture and leadership, and regulators have a very strong role to play in setting the standards that we should all be aspiring to as registered healthcare professionals.
Absolutely. One final question, conscious of your time. You alluded earlier to, of course, there's a huge backlog in the elective list for the NHS, 6.8 million people. The private sector has stood available to offer capacity and support and collaboration during the COVID period. It stands ready now. Part of that will be, the predicate of that happening will be that patients have a frictionless pathway to be able to use the private sector, either completely for treatment or for part of that treatment. What more can we do to make sure that pathway is as customer-centric as we can make it?
That's a very important aspect of being able to use the private healthcare that you've paid for. We at Bupa are very keen on enabling smooth pathways. We've invested in digital and virtual. We are seeking to make it easier for our consultants that we work with to be able to share data to hopefully make faster decisions when it comes to authorising treatment, so that we don't have the patient doing all the runaround.
Absolutely, and that I think will be quite a step change in people's expectations, and actually the demand is growing for that. So thank you very much for your time and your insights. I'll let you get back to the conference, and I hope we'll be able to have a chance to explore some of these themes again in the future with you. So for now, thank you so much, Helen.
Thank you very much.
My pleasure. I'm joined by David Furness, Director of Policy and Delivery at the Independent Healthcare Providers Network. David, thank you so much for giving your time today and joining us.
Oh, you're welcome. Hello.
You've spoken obviously at the conference. It's a post-COVID restriction world. The private acute hospital sector seeing new entrants, numbers returning in terms of self-pay very strongly, PMI as well back to growth. So from your perspective, a buoyant, perhaps an exciting time in this segment of the market.
Yeah, I think so. I think that's exactly right. So it is a time of kind of excitement because we're obviously coming out of the pandemic and all that entailed. It's a time of challenge as well, because we know that there's an enormous backlog of people waiting for care either on the NHS or even actually kind of looking to pay privately for care as well. And I think that presents tremendous opportunities for a sector that can be responsive and nimble and keep safety and quality at the heart of what it's offering to patients.
No, absolutely. I can't avoid talking about some of the reviews and the Patterson inquiry that looms in the background, and I know part of the raison d'etre and the mission that you have is to raise the bar on data and transparency. Just wanted to see if you can expand upon that, because that's one of the big things that I took from the inquiry recommendations.
Yeah, absolutely. So obviously the Patterson inquiry was a major moment for the independent sector, and I think it's an area where the sector has really come together to collaborate to try and make sure that patients have the safest and highest quality care across the sector. We've played a role in that at IHPN by co-producing with our member organisations and also organisations like the CQC, as you've said, the Medical Practitioners Assurance Framework, which sets out a standard of clinical governance that people can apply in their own organisations. We know the CQC are using that as part of their inspection regime as well. It's absolutely not mandatory, it's there for people as a guide to help them do things in the best possible way. But I think it's a really good example of the independent sector collaborating on safety, and we are very proud to be able to play a role in helping to make that happen.
No, absolutely, and that's something that perhaps isn't as well known in terms of the independent sector. It's clearly a commercial enterprise that delivers returns, but it's really pushing the envelope in terms of that safety, because that framework, I think, was originally launched back in 2019 under the auspices of Sir Bruce Keogh, but you've refreshed it recently.
Yeah, we've refreshed and updated it just in the light of kind of learning from the first few years of implementation. We're focusing very much on some kind of nuts and bolts practical support to help people apply that in their own organisations. And like anything, you don't want it to be set in stone. It has to keep developing. You have to keep building in the learning that you take and keep raising the bar, and that's exactly what we know our members want to do, and we want to help them with.
We're at it's a bit of a cliche, we are in a seminal moment across healthcare. You've alluded to the fact there's record waiting lists, elective waiting lists on the NHS, 6.8 million people. Part of the job of the IHPN is to advocate the role of the independent sector. And I think you've produced some research together with the Patients Association showing that actually fairly short distance of travel can have a quite profound effect in terms of reducing by perhaps I think 3.5 months, 2.3 miles of travel. So it's quite astonishing that
right.
tweak can make a huge difference in people's waiting time.
That's right. I mean, our analysis that, as you say, we did with the Patients Association showed that essentially the difference between hospitals with the longest waits and hospitals with the shortest waits for any given procedure were a lot less than people thought. And actually you don't have to travel far. There's something of a myth that patients don't want to travel for care. Well, actually, I think, if you give people the option of shaving months off their treatment, most people are quite happy to make arrangements to go 10 or 15 miles up the road, particularly if they're supported in doing that. But look, kind of patients have had rights to choose their provider for NHS treatment for over a decade.
Yep.
And we've never really cracked it. It's consistently bubbled along. Around 50% of people are aware they've got a right to choice. It's much harder to tell how many people are actually offered a choice, and we know from our practical experience that very often independent providers aren't part of the offer that's made to patients in terms of the options they have about their care. So we are absolutely pushing for choice to be part of the elective recovery programme. It's not the only solution by all means, but it is an important part of empowering patients to put them in control of their own healthcare.
Now, you'll do that obviously through your own advocacy. Do you have a level of confidence, because we are now in a place where the elective challenge is profoundly significant?
Yeah, it's a very difficult challenge, and our message to government and to the NHS is that our sector is there to help. We're just like we did during the COVID emergency. We see this as an emergency as well, actually, and we think that it's really important that what we have is a kind of all shoulders to the wheel approach. We should be using all the capacity that's out there to treat as many NHS patients as we possibly can. So it's very frustrating when you know that there's more that hospitals could do than they're being enabled to do. But equally, we recognise that the NHS lives in a world like everybody where it has limited resources and it needs to make decisions about what its priorities are, and we're just absolutely kind of pushing that message that we are there to help be part of that solution for the NHS.
Well, the statutory framework that the NHS has now obviously implemented with the ICSs has the spirit of collaboration and cooperation. Perhaps we might see that emanating more broadly in the short term.
Yeah, I hope so. And look, kind of one of the traps it's easy to fall into is that collaboration only applies to NHS organisations, and we don't think that's right at all. We think collaboration, goes both ways, doesn't it? But actually needs to incorporate all the independent sectors, social enterprises, voluntary community providers, and of course local government as well. So it's about collaborating across organisational boundaries, not just within them.
No, absolutely. Look, David, thank you so much for giving us your time and your wisdom, and I look forward to catching up with you later in the conference.
Thank you for having me.
Pleasure.
Thanks.
I'm joined by Leonid Shapiro, the managing partner of Candesic. Leonid, thank you for taking time out from the conference to join us. You're welcome.
My pleasure.
I wanted to just, it's 20 years, I think. I don't want to age you too much. Almost 20 years, I think, since you set up Candesic. Just be interested to hear a little bit more about the work that it does, because you work across public sector, private sector, investors, providers. It's the full gamut across healthcare.
That's right. So for about 20 years now, we've been working with clients, starting from investors looking to invest in healthcare companies, right through to operators and the NHS and government organizations, and also companies that work around the healthcare sector. So around insurance, around the technology side, and outsourced services. But everything is healthcare. A third of our staff are doctors, me being one of them, and so we're very healthcare focused.
And are there particular areas of speciality? I know you look at clearly the marketing strategy in particular.
We look at strategy and we look at investment. Our kind of ethos and our goal of why we exist is we want to help patients. We want to improve healthcare across the nation, and we feel that the best way of doing that is through the kind of work we do. I left medicine myself primarily because I felt that while being a doctor is very important, it is one patient at a time, where what I'm doing now, we as an organization can affect, thousands, if not millions of people through helping investors identify the best place to put their capital, not just to make a return, but to actually have impact in how the nation's health is improved.
Oh, excellent, thank you. We're at obviously the private acute healthcare conference here, a sector that I think is bouncing back, has bounced back from the COVID period. We've seen an increase in self-pay, PMI, so quite an exciting time for this particular sector.
It is. Unfortunately, it's because the NHS has just been inundated post-COVID with demand and also the challenges of capacity and everything else that everyone's dealing with, like staffing shortages and inflation. Luckily, we do have, as a nation, this independent sector as almost like a relief valve for the NHS. It does mean that people need to put hands in their own pocket, or companies need to put hands in their pockets to pay for private care. But we have that ability to expand the delivery of healthcare. So it's an exciting time for the private sector. Hopefully it's something which will enable the private sector to become an integral part of healthcare delivery to the country, as opposed to profiteering from a struggling NHS. But I think historically the NHS and the private sector have worked well together and have a lot of promise for it going forward.
No, and I mean, that was obviously demonstrated over COVID, where capacity was provided under commercial arrangements. Just expanding that very briefly, just to get your observations and expertise, we are faced with profound transformation. The NHS is under different statutory footing with integrated care systems, where collaboration and integration is very much the spirit, but we're also faced with a huge backlog, elective backlog. That's an opportunity and a challenge, but it also requires advocacy, does it not? What can private operators do to make sure that the debate around we are actually partners, rather than, as you said before, to be seen in contradistinction to the publicly funded sector?
That's always been a challenge for the private sector, because the NHS, there's two mentalities that the NHS has had in the past, or public sector organizations have had in the past. One is, do they treat the private sector as overspill and just as a supplier when they need it, or do they treat them as a true partner to help solve the needs of the population in their local area? I think we need the latter, clearly. We've seen actually in mental health more of that kind of collaboration, because it's a little bit more of it's a smaller club, if you may, mental health. So that we've seen a lot more. We've seen various mental health boards, government boards or NHS boards that have private providers, executives on them, because they're trying to solve the mental health issues in their local population. So there's no reason why we can't have that with ICSs, and there is some of that, but ICSs are still a very new organization, and it's not clear exactly to what extent private providers would play a role on that. But I think that in the long term, it's essential that we get the two sectors working together to solve a common problem.
Absolutely. You touched upon workforce as an issue. We're going to just touch upon it very briefly. We won't have the time to delve into the full details, but clearly in order to meet any of the demand, whether it's elective or it's private, we need sufficient numbers. Now, it's clear there are shortages globally, there are shortages over here. Some of the work that you've been doing with your clients, have you seen initiatives that give you some hope that perhaps technology could be an answer, perhaps international recruitment clearly a lever, but not a long-term panacea?
I think, our clients are doing a lot of things to try to increase retention. So they are paying more. They're giving more benefits. They're creating a career pathway. So people are tied in and more loyal to their employer. And educating them. I don't think there's a magic bullet here. I mean, clearly, if we can get international recruitment sorted and so on, but then there are many other countries around the world in the same issue. So it's not like there's lots of international people out there. We have seen operators take things into their own hands. So they've actually developed their own training programs abroad to train nurses, for example, in foreign countries under their effective organization, and then bring them across to the UK, as opposed to relying on recruiters to do that. So that's something that's very interesting, because I guess the larger providers, they need so many nurses, and it's such a problem. They can afford to invest in these type of effectively taking over the recruitment themselves. I think there's two issues with staffing, for operators. One is they have to pay more. So we have inflation, and we have alternatives that are, frankly, less, onerous than being a nurse or working in the healthcare profession. So there's challenges that it costs them more to hire the staff. And the second is the fact that the operators are. They're not getting enough staff to deliver the services they need to deliver, either from a statutory perspective, minimum staffing levels, or they have to cancel operations or cancel activity because they're not getting the staff that they need. And that's causing a spiral, obviously, because you've got increased costs, you've got decreased revenues, and if that continues, you're just going to get into more challenges. I think one of the things that the government can do to really help is. Look, I think in the long term, we are going into recession, and we will have a more freed up workforce. Okay. There will be lots of people that are unemployed in the next 12 months that will consider healthcare as a viable place to move their career. So I'm less worried in the longer term. The question is, in the shorter term, there's a danger of that if we don't get inflation under control, there will be constant pressure to raise fees, and people will move to competitors or to other jobs because someone's willing to pay them more. So I think it's great that we got this energy price cap. I think more needs to be done to limit inflation, and then we won't go into this spiral. And then we just need to wait until the recession kicks in, and then we have a bit more freedom of labor market.
No, it's a huge conundrum. We don't want to solve it here. One final point, just from your 20 years of perspective as a clinician, we're seeing now that transition to the vision of the 5-year forward view, the long-term plan, a move away from an acute setting to a community setting for delivery, and a joined up, or at least a nascently joined up ecosystem, whether it's primary care, secondary care, mental health you've talked about. Are there areas that, particularly working with investors as you do, this is obviously a chance of some innovation and an opportunity?
Yes, for sure. So there's a lot of investors that are looking to the U.S. model. So a lot of U.S. Surgeries have moved to day cases. So now you can do like knee replacements and hip replacements on a day case basis. Hasn't quite come to the UK yet. They're experimenting with it, but there's no reason, clinically why it can't be done. And we've seen today in the conference how there's been a big decline in actually inpatient activity and a lot more in outpatient activity.
Yeah.
So, and the work we're doing with developers and investors in healthcare, they're much more interested in starting day surgery type businesses and diagnostic centers than they are big hospitals, old style hospitals with lots of beds. I think if anything, we're going to see hospitals of the future have very few beds and a lot more theaters and also procedure rooms. They're not necessarily going to be full anesthetic, but just things where you can do things on a day case basis. So that's really exciting. That's where the money's going in now.
Clearly, Candesic will be extremely busy over the short and medium term. In the meantime, thank you very much, Leonid, for your time. It's always a pleasure to hear your insights and your wisdom.
Thank you.
Thank you. I'm joined by Professor Gordon Wishart, the founder, CEO and Chief Medical Officer of Check for Cancer. Thank you for making time today to join us, Gordon. Really appreciate it.
You're very welcome.
I wanted to really get into the cancer debate, the issue. The numbers for non-specialists like me are frankly terrifying. 10 million people dying worldwide in 2020. The projection showing that we may in 2040 have over 27 million new cases per year. Just to put that in the framework, the government has declared a war on cancer. You've gone on record as saying there's a cancer time bomb. Would you like to explain a little bit about that?
Yeah, I think that there's no doubt that the successive lockdowns really caused a lack of access for many, many patients to cancer services. And we're now seeing that now, and pressure on the NHS, some of the worst waiting times for cancer diagnosis and treatment that we've ever seen since records began. But more worryingly, published data that shows really much later stage diagnosis in prostate cancer, bowel cancer and lung cancer. So the government's target to improve early cancer detection and get 75% of patients diagnosed with stage 1 or 2 within the next few years is really way off the mark. So I think the war on cancer is words, but really without any substance.
Now look, thank you for your candour. Now you've distinguished expertise as a cancer specialist, cancer surgeon for more than 2 decades. I think it's about 6 years ago you took the decision to set up Check for Cancer. Can you give us a little bit of background about what drove you to do that, and obviously the focus that you have on rapid and audited access to those tests?
Yeah, I had a great career in the NHS, clinically, research, a lot of academic work, but I think I always felt that the private sector was really lacking in showing that it provided quality services, and then I was heavily involved in writing reports about Ian Patterson, the rogue breast surgeon, and so that really led me to say we can do this much better, but we need to provide outcome data. We need to prove that we're actually doing a good job, and that's what led me to set up a UK-wide network of breast cancer specialists that could deliver proper one-stop diagnostic clinics, and we would audit them and show these are the data. We've got great outcomes.
And cancer, it's obvious to say, is a challenging experience for anyone who's dealing with it, their families. So the idea of having data and transparent communication coming out of Patterson is very, very important.
Well, I think so. I mean, that was really the nadir in terms of outcomes, and so we have to do much better. And it's great that all the discussions this morning have been focusing on patient outcomes and experience, and I think that's great. We need patient-centred care, but we need that transparency to show that we are delivering what we said we would deliver.
I'd like to find out a little bit more some of the initiatives that you've developed, and one that's caught my attention was the first worldwide breast cancer risk test. Can you tell us a little bit about that and its take-up and the impact that it's had?
That's a combination of a traditional lifestyle and family history questionnaire with a salivary DNA test that gives you a much better personal risk assessment, and that allows someone then to manage that risk, perhaps to introduce behavioural change to reduce the risk and to look at screening the risks and benefits. And we can now do that for up to 6 common cancers.
Thank you. Just one final question. We're here at the Private Acute conference. So the insured and the self-pay market, it has a really significant role to play in the fight, in the war, if we like, against cancer.
I think that's right, and I think we'll see more and more patients looking to bypass those long waiting lists for diagnosis and treatment by using the private sector, and we should be there to help them with that.
Well, we look forward to welcoming you again and hearing more about this, and thank you so much for your time, Gordon, today.
Thank you for having me.
My pleasure. I'd like to say thank you to all the guests who shared their time and their wisdom. If you've enjoyed this episode of Voices of Care, please like, follow or subscribe wherever you receive your podcasts. And if you want to find out more information about how we are truly enabling the healthcare workforce of the future, please visit newcrosshealthcare.com/voices of care. In the meantime, I'm Sahel Mirza. Goodbye and thank you very much.